I'm ready to rock and roll.
Okay, Luke, if you'd start.
Right, everybody. Right, welcome everybody to the Health and Wellbeing Board. County Councillor Richard Dodd, if anyone doesn't know, and this is being live streamed. Okay, apologies for absence. Leslie?
Apologies from Ralph Frith, Councillor Renner Thompson and Graham Sayers.
Right, okay, anyone else from the floor? I can't see any hands, or not that I can see any hands, but I can't see any indications. Minutes. Oh, Susan Dungworth. Susan.
Yeah, sorry, I was a few minutes late there, Chair. I need to apologise. I need to leave at 10:30.
What are we doing?
For an urgent meeting. I might be able to come back in afterwards if you're still going, if that's okay.
Well, what I'll do is if we're done, I'll send you an email.
Right, thank you.
Right. Minutes. Nothing. Disclosure of members' interests. Take your hand down, Susan, if you can, then I can get a refresh. Right, items for discussion. I'm going to go to item 4, but I'm going to update integrated care systems because we've got Sir Jim Mackey with us and he's going to present this because I know he has another meeting. So straight over to you, Jim.
Great, thanks, Chair. So you've got the slides, and there's obviously a lot in the media currently about the ICS legislative changes, with it all being formally launched today. So if it's okay, I wasn't planning on ploughing through each individual slides. I'll just tell a little bit of a story as to where we've got to and then where I think the emphasis should be. So the NHS has been messing around with this really since about 2016 because of the confusion we were left with after the 2012 reforms. So we've been through a few iterations and tried to move away from the very hard-edged competition law, everything must be tendered, CMA position, etc., that we've had out of the 2012 proposal changes, and also try and encourage people to collaborate more rather than competing with each other. So I don't think any of us would agree with that, but we've been through a pretty complicated and long process. So I see this as near the end of that process and trying to formalise it. And again, because of where we are with 2012, it's trying to deal with so many things at once. It's quite hard to explain and deal with them all at once. So on the one hand, there's a tidying the NHS's local function or create a new kind of headquarters for the NHS within the integrated care system and make it a legal body that can receive money, etc., because currently it can't. And then on the other, an emphasis on working with partners, especially in local authorities, around health improvement, which I'm sure Siobhan will touch on in a moment. The problem with that is every ICS is different. So we've got a 3.5 million population, 70 odd primary care networks, 13 top tier local authorities, and some of them have got like 2 councils and 6 PCNs. So the operating model in terms of how we deal with that's really quite different. So what I'm hoping, and again, just before I move into some of the detail, is it's written quite loosely and in a permissive way, which reflects the fact that everybody's in a different place. And I see that as a really big opportunity for us to shape locally. There's been much less emphasis on place in the media and the politics over the last 48 hours. And I think if we're honest, we'll see that that's really where the strength is. So I think that gives us freedom and space to shape things according to our needs in Northumberland and then similarly in North Tyneside and colleagues in Newcastle, etc. So I would really hope that we can use this to build on the transformation board working that we've got, tweak the membership a little bit so fully embrace primary care networks, etc., and then use that as a mechanism that allows the ICS to devolve things to us in our local place, and we work together there where it makes lots of sense, rather than getting caught up in the confusion as to how to reconcile our interests with the interests of people in Redcar, etc., in the broader ICS thing, and a really big focus on health improvement and inequalities and the impact of COVID in terms of how we recover things, etc. So it's as always with these things, when people change the law in the NHS, it usually provokes one of two responses. One, you jump in the air and punch the sky because there's something fantastic in it. I think that was always going to be very unlikely at this point, given the mess that's got to be tidied up. On the other one is you throw your cup at the wall in disgust. And this doesn't really do either of those, which I think is probably a good thing. I think it gives us quite a lot of space to shape locally, building on, you know, what's a pretty strong and effective system. So there's still a lot of detail to work through. It hasn't obviously been through all the legal processes and parliamentary processes. There'll be lots of arm wrestling and stuff through that. But I don't think anyone really argue about getting rid of all the competition law and the need to tender things and, you know, the role of the CMA and all those sorts of things. And I think the ability for us to be able to shape this locally to suit the needs in Northumberland, which is a pretty complex geography with complex issues as well, I think is probably a good one. And what I would just say on that as well, I had a session with primary care colleagues last night. We've got to get a hold of this and really shape it to suit ourselves. Otherwise, if we're still working it out in August, we will be subject to a national template and it'll not fit. So I think I'd really like us to try and get into that space really quite quickly. So I hope that makes sense, Richard. I'm happy to just open it up and pick any questions up.
Okay, thanks, Jim, for that. Maggie Bailey.
Hi, thanks for that, Jim. I represent Northumberland's CVAs, the Executive Assembly. You haven't mentioned the role of the VCSE sector in Northumberland with this new ICS structure. So can I just ask for the record, what do you think will be the role for the VCSE sector in Northumberland in particular?
So you've got a huge role. It wasn't a deliberate omission. It was just in my rush to try and explain what was going on. I missed it out, and I think we really need to think about how you can be incorporated onto the transformation board arrangements as we'll make them more have more legal standing over time. So I think we'll probably end up in a place where there's a kind of committee in common for the transformation board with refreshed membership that fully embraces the contribution that you and others can make. We need to be a bit careful not to end up with 400 people around the table, but I think we can manage that. And I think when you look at what we've got to deal with ahead and the things that we're all worried about in terms of the impact over the last year, we've just got to embrace as much energy as we can. And if there's a will, we've got to go with it, I think.
Right, I've got Councillor Veronica Jones next.
Sorry, the mute button's in different places on different versions, isn't it? Sorry about that. Yes, as you know, one of the benefits in Northumberland is the close working relationship with the NHS, and I know that makes us nationally very good. Unless I'd missed it, various versions of this progress, I can't see that link with the council that links us, for Northumberland formally into this. Where will that lead us?
Yeah, so they're silent on how this works at place because it's just very different everywhere, Veronica. And in some places it's a source of huge contention and difficulty. So they've tried to focus on how the ICS level bit works, so our broader northeast interaction, which will largely be through the partnership board mechanism and also place on the actual board, I think. But also the other thing that I think they've ended up, struggling with was the general local government response was a bit mixed on the ICS thing. So on the one hand, it was, honestly, do you really need to reorganise now? Was one point, which is a fair point. Second point was, what about social care? And then the third bit about, don't tell us how we need to interact with people locally. So in some places that'll be very integrated and joined up. In other places, less so, but everybody being encouraged to try and work together. And also just a real nervousness about prescribing a way of doing it to allow people space to find their own way. And I think that's really important given how different people are around the country.
I've got Jeffrey Watson, councillor.
Hi, yes, Jim. Just a very broad question. One of the big problems that NHS has got, and I'm sure all of us will agree, is the amount of sort of administrative arms there are and amount of red tape and stuff. You touched on it earlier. Do you think this new system will help to erase some of that, or will it simply add another level?
So I think there's a risk of it adding another level, Jeff, and we have had lots of discussions about this. So my view would be it needs to go further in tidying up the national bodies and how they interact, and probably then rationalising the regional infrastructure. So what we don't need is a big regional office and a big ICS team. So our regional team view the ICS as very much part of their infrastructure and devolving things to them and then devolving them to place, etc. But I think that's something we need to keep a watching brief on, Jeff, and make sure it doesn't end up being a further expansion and a confusion. I think there's enough will to make it less so and tidier and clearer and less costly, but we will have to keep the pressure on. I forgot also to mention, and I should have done, is there's a very strong view centrally that health and wellbeing boards can be reset as the bit that holds us all to account, and that was really the intention of the 2012 proposals and got lost in the complexity. And also they're just very different around the country as well. So I think the fact that we've got good functioning health and wellbeing boards here and in North Tyneside, I think we should just take the opportunity to make sure that you are able to hold these new mechanisms to account. And if you're not happy, speak up and, you know, we'll go and sort it out.
Right. Anybody else? I can't see any hands. Nope. Thank you, Jim. Release you for your duties.
All right. Thanks very much.
Cheers, Jim. Thank
Bye.
you very much. Again, this was a report presentation. We've had that. Claire.
Richard, Siobhan and the team were just going to share a quick update off the back of that regarding system transformation. I don't know if you want to go to that now.
Okay, yeah.
Thank you very much, Chair. So this follows on really neatly from what Jim was talking about and what we want to do here. And I've got Dr. Robin Hudson with me here as well, who's a GP and a medical director. And what we want to do is give you kind of the human touch about how this will work. And also this is an assurance for you as a board about what our System Transformation Board is doing. Very much in the space of outcomes, inequalities, what COVID's done to our population and how we start to recover that. And picking up on the points earlier, how important communities, neighbourhoods and the voluntary care and the care sector matters in all of this. So if you can just go to the next slide for me. And then I'll bring Robin in. So here in Northumberland, and we're going to come back quarterly to report to you, based on the health and wellbeing strategy and the 4 key priorities that we've got, we've developed a range of 8 programmes of work that sit under that. And as collaborative as we are and as good as we are, we still all know, and Robin will come on to this in a second, that some of our outcomes and the gaps in terms of life expectancy and inequalities really vary. And secondly, we all know that it's not just healthcare that's going to solve this, it's all of us together. It's our transport, our leisure, our business, our education. So I'm going to hand over to Robin now, who's going to take you through and give you some examples from a human people perspective about how we're thinking about this. Robin, over to you.
Yeah, thank you, Siobhan, and thank you, board, for letting me speak. I'm not going to labour these slides. I'm going to try and give you a bit of an overview because hopefully you will have had an opportunity to look at the slides. You will probably have seen these building blocks of something called population health management, and I want to really get beyond that. Siobhan's already alluded to the problems that we've seen as a result of Marmot report on health inequalities, and also with COVID. I think that has further highlighted the problems that we're seeing caused by deprivation and the impact on health. I want to try and answer the question, so what? We have this thing called population health management. We have a method to it, but so what? And if you just take the next slide, please, Alan. This is much more than a medical model. This is a community model. And quite reassuringly, it's about health and well-being. which is actually part of your raison d'etre, really, as a board. It's looking at all these other factors which affect health. So it's not just about good, excellent healthcare. It's also about good housing. It's about income and employment. It's about good education for children and adults. And it's also about the relationship with lifestyle issues, obesity, smoking, alcohol, and all these things we're well versed on the impact, with their impact on health. And I think the question I want to put to board is about, Liz Morgan made this point yesterday, it's about community aspiration. How much do our communities aspire to touch on and deal with these issues together, with support, with the right resourcing? Next slide, please. So our public health colleagues will tell you all about these other factors which have a big impact on health. And green spaces are there, strong communities and resilience is there, as well as the statutory functions that we fulfill in terms of public health, prevention, and all the medical things that we do. Next slide, please. So I'm just giving you, these are two case studies, and we are in the process of actually developing our own case studies for Northumberland, which I'll explain a little bit later on. But this is the kind of thing that we want to be focusing upon. Okay, so in Blackpool, there was a case study, somebody called Barbara, that's anonymised. And really, the focus is upon health coaches and about focusing upon the broader issues that are affecting Barbara's health. And actually, those issues were to do with housing, employment, struggling with bereavement. And the solution was actually identifying Barbara, but then putting somebody in alongside her to help connect her to the correct services. I don't think this is real rocket science we're talking about, but if we replicated these kinds of individuals across our county, and we actually start to think about the interventions and signposting, I think we can have a massive impact upon our population health. Next slide, please. And then PUDSI, the thing I wanted to pull out for this PUDSI cohort is really about data. And this is about identifying risk. So this individual called Paula was a little bit off the radar. They weren't very obvious. They'd sort of disconnected from our community and health services. And by looking at data, we were able to actually identify risk. And the risk was actually nutrition, poor nutrition linked to poor outcomes. And an intervention was designed around that individual. So data is going to be really key here.
David Thompson.
Next slide, please.
Is now exiting.
And then this is the final slide. So this is what we've developed over the last 6 months in terms of roadmap. Starting at the left-hand side, we are looking at, there's a balancing act we've got here. On one hand, we need to bring leadership to the system, and all of us have a role in that, including the voluntary services, voluntary agencies. But on the other hand, we're trying to grow something at grassroots, some kind of social movement, and this community aspiration that we're trying to harness and develop. And that's there's a bit of a tension there, I think. We don't want to top down tell you what to do to the communities, but we do want to enable them to find it for themselves. So co-design is really important, and we already have forums like Northumberland Communities Together, where we have the voluntary agencies and the social services meeting. We need to expand that and grow that. We're already looking at resourcing across our multiple sectors. We're looking at our data sets and how we share data between general practice, the hospital system, and social care. And then we're starting to think about how do we identify and focus down on our key areas. And in the Ashington area, we've already identified a number of risk cohorts. So these are people with emerging risk, maybe at risk of developing diabetes, and that maybe they're overweight, maybe they have mental health problems. And we're starting to think about how we can actually help them understand how to get out of that negative cycle. And then the final point is also regarding our finance and contracting arm. So just last month, we've done a large data trawl to look at how
is
money
now joining.
to look at how money can flow around the system more effectively. And maybe with the new ICS changes, that will give us some of the permissions that we need in order to scale up and really make a difference. So I think that's really where all I wanted to say on that. So I'm very happy to answer some questions if necessary.
Okay. Anyone? I can't see anybody asking any questions. Jeffrey Watson, councillor.
Thank you. Just a small point, but it bugs me a little bit when I don't understand something. On the Blackpool intervention scale case, the very last paragraph, Barbara's patient activation rose from a level 2 to a level 4.
Yeah.
I don't know what that means. I'm sorry.
Yeah. Well, I was actually going to explain that, but because of brevity, I skipped over that. So I'll give you a concrete example. So in Ashington, we're running we're doing some questionnaires. We've identified a number of patients, individuals who we're going to have a conversation with. And how do we work out, number one, their well-being? How do they feel about their life? And there is a questionnaire called a Wellbeing Star. It's a national questionnaire which helps us identify what are the barriers and blocks to their health. So not just talking about their healthcare, but housing and other things. There is also another questionnaire we're asking them, and it's something called patient activation measures. And I think in plain English, that is their readiness to change, because not everybody's ready to change. A concrete example would be smokers. You know, I might say to you, you know, smoking's bad for you, and the individual says, yes, I do know that. Do you want to stop smoking? And obviously there is a range of responses to that question, from no way, I've got too much on in my life, to yes, I've had enough of spending all this money on cigarettes. And that's, in plain English, that's what it is. It's working out where somebody is in their readiness to change, and then helping them to move to a place where they are ready to change. So that, sorry for the jargon, but I think that hopefully explains it.
You follow that, Jeff?
I did, and thank you very much for taking the time to tell.
Right. Okay. Anybody else? This is sort of like an addendum. Yes, Veronica Jones, councillor.
Yes, thank you. I think you probably answer this in the way I expect, but I just wanted to be sure, because, you know, this is all good stuff. As you know, our Health and Wellbeing Board strategy plan is along these lines with the wider determinants and everything. The council's own corporate plan, as you probably know, has public health written all the way through it, and all these issues come into there. I just wanted to be sure that we're not sort of doing this in different sections, that this is all joined up and you're not reinventing what's already happening. And I'm sure you're not. I just wanted to be sure.
Yeah,
okay.
we are not reinventing. No, I think we are, I suppose, re-energizing those relationships and refocusing our vision. There's so much work going on in our county, but I think maybe the biggest challenge we've got, we don't know what everybody else is doing. So it's not about telling people to stop what they're doing, but it's about harnessing and galvanizing and focusing that vision towards this direction, towards health and well-being. I don't know if anybody else wants to make a comment on that.
I've
Liz,
got two or three. I've got Kath McAvoy-Carr, then Liz Morgan.
Thanks, Chair. Just to reaffirm that issue about the amount of work that's going on in the county. At the System Transformation Board yesterday, we did a bit of a quick workshop around Best Start in Life to look at actually what was going on across the county and offer some challenge about how the systems work together, because we talk about it. Best Start in Life is in the health and wellbeing strategy. It's in the Children and Young People's plan. We've got an early help strategy. We've got safeguarding strategies that include early help. So the System Transformation Board yesterday started a process of actually looking at some of those individual areas and determining what work was going on and the impact that was having on across all of the partnership areas. So I think it's something that we've always been cognizant of, but I think we're much more aware of that now. And actually, we've got to stop working in those silo areas, developing systems and processes, and actually start those conversations as a partnership or as a system rather than in individual local agencies.
Okay, Liz Morgan.
Thank you. I mean, I just wanted to provide assurance to the board and to Councillor Jones that we are absolutely joined up on all of this work. So, you know, the work that we're pushing forward in the council to you know, adopt a health in all policies approach, that's all achieving the same aim, but just through a different mechanism. I think the point is that you know, we can't treat people in isolation. If we treat them and then discharge them into the circumstances which are making them ill in the first place, we're just going to end up with a, you know, a cycle of ill health. So this is a way of breaking that cycle really, and really putting people back into a good position to become well and maintain their well-being.
Right. I think I've got Kath McAvoy Carr hand up, but I think it's an old hand. Yeah.
Richard, sorry to interrupt. It's David Thompson here.
You've got no hand, but I'll let you go on.
Well, I've got no hands and I've got no picture either. Apologies for that. Try as I might, I just cannot get through on the Teams link. Anyway, just I am here and I am listening. So, and I may ask a question or two later on.
Well, just burst in as yeah. I would hate to miss your contribution, David.
Yeah. Okay. Cheers.
Right. I have no one else I can see, so I'm going to move on to the next item. Now then, I'm aware that Claire Malone has to be away by 11 o'clock, but I think we can get the update on the COVID-19 from Liz Morgan in before Claire needs to be away. I'll go straight to Liz.
Thank you very much. Okay, so can everybody, hopefully, can everybody see that? Right, okay. So, so this is the sort of regular update that I do for the Health and Wellbeing Board in the board's capacity as the Outbreak Prevention and Control Board. So we'll just start off with a bit of a an update on where we are, and this graph is looking at the 7 local authorities in that LA7 group, and you can see that every local authority has a very similar pattern. We all had that peak at the beginning of January, which for most local authorities is continuing to fall off, although there are a couple, North Tyneside in particular, which has hit a bit of a plateau over the last couple of weeks. And this is just comparing what the picture of the transmission looked like at the beginning of January compared to what it looks like, you know, a month and a bit over. So I don't think I need to explain this any further really, but, you know, clearly things have improved significantly, and our rates are, you know, nearly 2/3 of what they were just over a month ago, and I think that is a fantastic testimony to the efforts that our communities have made to comply with the restrictions and really, you know, follow that face, space, hands concept. And again, this is just showing the epidemic curve from a Northumberland perspective. Again, just showing that fairly gradual reduction, which is probably what we would expect to see, because, you know, we're not in the same place that we were in March in terms of the lockdown. It isn't quite as strong as it was back then. You know, we have got schools open, we have got a number of shops open doing click and collect, which we didn't have before. So for a number of reasons, we would expect to see that drop in cases being not quite as acute as it was perhaps earlier in the year. And I think this is also something which is contributing to the slower rate of reduction, and that's this, we call it the new variant, but of course there are newer variants than this now. But this is the one that started in the southeast and which actually is now the predominant coronavirus variant in the country. And these maps just show you the extent to which that variant has spread, and of course it is one which is significantly more transmissible. So the fact that actually we've been able to maintain that reduction in cases in the face of a circulating strain which is much more transmissible is really good news. And certainly for Northumberland, probably between 2/3 and 3/4 of the cases that we're now seeing are suggestive of the new variant. So, you know, even in our county, it is now the predominant strain. And then from an age perspective, we are seeing a reduction across all age bands. It is most striking actually in people over the age of 65. I think the rates have almost halved over the last few weeks, which is really good news. And I guess that's what we would expect to see if the vaccine was doing what we hoped it will do. I think there maybe is still a bit of work to do in school-aged children, that those cases are not dropping as quickly as we would like to see. So we probably need to just unpick that a little bit more to find out what's going on there. And then this is just another graph which really confirms that reduction in rates people over the age of 60, and of course that's really important because it is those older age groups which are more susceptible to severe disease. So in terms of the outbreak prevention and control plan then, and how we're progressing with that, one element of that is around testing, both the PCR testing, largely symptomatic testing. And of course, we now have a wide variety of symptomatic testing sites across the county, which you're well familiar with. The mobile testing units do shift around a little bit, and we have now actually got 2 sites in Cramlington, so we're trying to just make sure that those 2 sites are deconflicted. One of them actually belongs to North Tyneside, and one of them belongs to us. And of course, we can flex those mobile testing units around depending on what the needs are across the county. And you'll recall that we did bring in additional capacity to support Halt Whistle when we had that community outbreak in December of last year. But overall, actually, testing has maintained, you know, has maintained at quite a good rate. It's continuing to be quite buoyant, which is really good, because we want to encourage people who are symptomatic to get tested. And then the positivity rate, which is the proportion of those tests which come back as positive, that's slowly reducing, which does suggest that actually we are genuinely seeing less infection in our communities. The lateral flow devices, so these are these quick devices that give a response within about half an hour, ostensibly aimed at people who don't have symptoms. The schools programme has been running since the first couple of weeks of January. The care homes programme has been running for a little bit longer than that. There is, they do change quite frequently. So certainly for primary schools now and maintained nursery schools, they've now moved over to a home testing process, and I think that will, that's probably the preferred direction of travel if we can encourage the Department of Health to go down that route. And then just a couple of minutes on our targeted community testing. So this is basically a Department of Health driven initiative to provide quite a wide availability and accessibility of community testing within local authority areas. And again, this is identified at people who don't have symptoms and who don't have access to asymptomatic testing through any other route. And there is quite a significant employer-led programme which was launched on Sunday, aimed at businesses with a workforce of greater than 50 people. And so employers can register and get testing done in their own workplace, which would be a preferable option from our point of view. So the targeted community testing that we've got in place as local authority, that started in Ashington Leisure Centre the week before last. It opened in Alnwick and Hexham Leisure Centres last week, and we're looking at how we can extend those opening hours to the evenings and the weekends. It's staffed by both volunteers from our own organisation, but also Active Northumberland staff, and Active Northumberland have been absolutely fantastic in encouraging their staff who are furloughed to come out and actually support this initiative. And I think, having been to the Ashington testing site last week, you know, the staff are absolutely delighted to be supporting this initiative. They're really pleased to be out of their homes and working again. And I think actually it's as good for their own well-being as it is for reducing transmission across the county. And we're also supporting fire and rescue to do their own testing, and we're testing within our own workforce. So I've just identified there who that community testing is aimed at. I think some comms went out last night to provide an online booking service. So we'd encourage people from all of those cohorts to book themselves in to be tested regularly, ideally twice a week, so that we can just identify, or at least help us to identify those people who have infection but who aren't symptomatic. And then the last thing just to talk about is the local tracing partnership. So we started that on the 4th of February, which was last Thursday. And this is basically the first step in developing a holistic local contact tracing service, which takes over actually the whole of the process. At the moment, that tracing partnership is just restricted to those individuals who the National Test and Trace system have been unable to contact, or who haven't responded to their positive result within the first 24 hours of that result having been released. So it is a relatively small number of people, but it is that they are people who have been resistant to engage with the National Test and Trace service. I think there are advantages to us for developing this. So firstly, it does enable us to become familiar with the NHS Test and Trace contact tracing database. We know from the experience of other local authorities that actually local authorities working at a local level are much more likely to be able to contact these people than the national services. And so we're using a local phone number because we know that people are more likely to respond to that. And it also enables us to have a wider conversation with individuals about their personal circumstances, whether they need support to self-isolate, because again, we know from the evidence that actually quite a large proportion of people find it very difficult to self-isolate for that 10-day period. So actually it gives us an opportunity to talk to them about the availability of the isolation payments and the support that Northumberland Communities Together can provide for them and their families. And then finally, it will enable us to improve the quality of the data, because actually if we have a conversation with somebody and they explain to us that they've been in a school setting, we need to know which school setting that is, what's the postcode, which workplace is it that we're talking about, because actually only if we have that level of detail, that quality of data, are we able to link together potential chains of transmission, which at the moment is quite a challenge. And that's sort of just a model of what the actual process looks like.
Okay, are we done, Liz?
I've got a few more, but which I'll just quickly whiz through because I'm conscious that Claire has to go at.
Yeah, I'm going to go straight to Claire after you finish, and then take questions after that.
Yeah. Okay. So from a vaccination point of view, and Rachel's going to come in and talk about the vaccination schedule in more detail later on in the agenda. But I think this is just to provide you with some assurance that we recognise that we are going to experience, if we're not careful, significant inequalities in terms of vaccination uptake. So we have got a vaccination equity plan, which is being developed to both make sure that when we're rolling out the programme, we can think about how we mitigate against inequalities, but also how we work proactively with those communities to ensure that they understand the importance of the vaccine, and how we work with Rachel and her team in the CCG to enable access. I probably won't go through these. The next 4 slides are the sort of more detailed slides about the 4 wraparound teams that we've got to support care homes, education, workplaces and high risk settings and people. And I'm just conscious that time is at a premium, so I'll leave that for the time being. But we'll come back to this later in the agenda.
Right, I'm going to go hold your questions or whatever comments. I'm going to go straight to Claire Malone because they're all linked. Communications and engagement, and then we'll take any questions on that on both presentations after that. So Claire, over to you.
Thank you, Chair. I'm just going to share my screen. Hopefully you'll be able to. Oh, it's trying to share. Bear with me. Now, can everyone see that?
Yes.
Fantastic. Okay. Good morning, everyone. So I am here just to talk a little bit about some of the communications activity that's been happening over the recent months. We've had lots going on. So we'll start straight away talking about the social media communications. Is that loading for people? It's not loading for me, unfortunately.
I've got blank screens.
Yeah. I'm going to try coming out of it and leave it.
It's there, it's there.
I'm just going to show it on this view then, rather than the proper presentation one. Okay, so starting off with the social media, we're continuing to share all of the national messaging at the moment. So that's the government and NHS messaging on our social media posts. It just reminds people to follow all of the key advice, staying safe, staying at home and exercising close to home when they do go out for their essential activity. We're also doing an awful lot on our social media to do with vaccinations and just re-emphasising the key messages around vaccines and trying to dispel some of the myths that are out there. And we are also continuing regularly to share the dashboard information that Liz referred to earlier. And most recently, as she mentioned, we've started to promote the community testing for people who don't have symptoms. So that's on our social media feed, on our website, and PR went out yesterday, so you should sort of see that in the media in a lot of days. But we've got lots of proactive and reactive work alongside that. With reference to the wraparound groups that Liz mentioned before, we've got various bits of activity going on. So, for example, care homes, we support the team with regular weekly newsletter that goes out to care homes and providers, just making sure everyone's up to date on the latest information and government advice. We do the same with regular updates to education. We are working with the other local authorities in the LA7 to develop a business pack for the hospitality business sector, and that will help get them ready and support them when they open up again. So it's not tier specific. We know there's a chance that there won't be tiers when we come out of the other side of lockdown, but it's very much about supporting them to be COVID safe when they open again. And we're working closely with a high risk wraparound group as well, just to make sure we provide information in the correct formats into the correct groups for them. As well as the regular briefings that go out through various panels, we've been working again with the LA7 on the regional campaign. So that's on the ongoing campaign development. You'll still see that running. I'm sure you've all seen that when you've been out there. We're developing a workplace safety campaign again for when businesses open again, so wider than the business pack I mentioned earlier. This is actually going to be a campaign activity to help everybody. And we're working in the region to look at vaccine hesitancy, in particular with the BAME communities, and we'll be developing a targeted campaign. So work's just started on that this week. We've got ad vans running over half term and digital vans, just reminding people to stay local and stay at home where they can. The community champions, we've talked about previously, but they're up and running now. So over 50 champions have signed up so far. We're still actively recruiting, so anything any of you can do to help promote that, information is on our website. 27 of the champions have already finished an induction session, so we're actively sharing our messages in the community. There's actually another induction session today, so the remainder of those have been invited along to that. They get weekly updates from us with the latest information, and we share graphics and things like that with them so they can help spread the word. And they're going to be key in helping us get the advice out when we do come out of lockdown, so they do play a very important role. Their key point of contact is someone in the NCS team who is the volunteer coordinator. She's been playing a vital role. And we include the latest information. So, for example, this week it will have something in about the targeted community testing. Next steps on this will be looking at rolling the champion scheme out with some businesses, trying to get some key partners on board so they can help spread the word within their organisations. The Beat COVID North East campaign is still running, so just wanted to give you a little bit of an update on that. Since the 22nd of January, we've had adverts continuing to run on TV, radio, press, out of home adverts, digital, bus rears, etc. And the lockdown message will be rolled out across the various channels for that. We have diarists, so the people that are featured in the campaign do diaries for us, so keep a little blog going that's on the website, and we've done lots of media to do with that, so people's interest in those. They're real people, and it makes it a real for people to help understand the impact of COVID. And we're continuing to challenge myths, and we'll keep an evaluation going right the way through to make sure we're monitoring the awareness. Just to give you a little bit of a feel for how this looks, this is some of the ad vans that have been out there, and they've been in local hotspot areas and across the area. They'll continue to be in key areas that tend to attract lots of crowds over half term, and we've got adverts that will run in the weekly papers, as well as bus and petrol advertising and PR. Few of the bus rears there, you might well have seen them when you're out and about, and also we've had bin wagons. Council bin wagons have featured the campaign imagery and on some of our fire appliances. The other activity that we've got coming up in the next few weeks, we're continuing to amplify all the national messages, national campaigns, and we're also refreshing our town centre signage. So really hammering home that stay local message. And as you can see from the graphic here, we outright ask the question, do you really need to be here? So just really to encourage people only to travel for essential purposes. We're continuing with our champion recruitment and our Beat COVID campaign activity. The other thing I just wanted to mention on there, it mentions the further behavioural insight work. We're doing a piece of work with 11 other local authorities in the region to look at the behaviours of care home staff, teaching staff and healthcare providers and how COVID has affected them. This will help us understand if there's any further support we can give, any further messaging, any further training, that kind of thing. So that piece of work's ongoing. The one-to-one discussions will be finished in the next couple of weeks, and then we'll be able to give some feedback on that. And that's it from me.
Right. Claire, I see that you have a matter of, we can do any questions on comms to Claire. We'll do them now. Then I'll go back to questions to Liz so that you can go to your meeting at 11 o'clock. So any hands, questions on the comms and on the presentation you've just seen? You're going to get away quick, I think.
Oh, I've got off easy.
Yep. Right, okay. Thank you for that. We'll see you whenever. Can we go now back to questions to Liz Morgan on her COVID report. Any hands?
Richard, pardon me, Richard.
Yeah, okay, come on, David.
Thank you. Just three very quick things, if I may, about issues which have been raised with Healthwatch Northumberland. One was a very small number of people who had difficulty accessing the vaccinations, but the information has been passed on from Healthwatch to the GPs and the CCG, so that's sort of being taken care of. A second one, which came through the Healthwatch, was over contacting care homes because of the restrictions of COVID and the worries about that. But Healthwatch had a recent online forum with relatives of people who live in care homes, and there was a much more positive picture in terms of visiting pods and video calling and so on. So that is improving, and Healthwatch is planning to engage with care homes to find out what has worked well with them in this context and pass it on.
Okay.
Excuse me. And the third one was over unpaid carers. That also came through the Healthwatch and the difficulty they had in accessing the vaccines. But Healthwatch has been working with Deborah Blakey, Carers Northumberland, to compile lists of these unpaid carers and working with GPs and so on. So that's also progressing. So three, each one sort of fairly small items, but the responses from County Hall, etc., has always, in every case, been very positive and seems to have made a difference. So that's good, and thanks to everyone who've helped with that.
Right, I'll go straight to Liz to answer or give something back on that, Liz.
No, I was just going to say thank you very much for that, and I think any feedback that you've got on the experience of care homes would be very welcome. I just wanted to say actually that Rachel's here to provide you with a sort of more specific update on vaccination, but perhaps I don't know, Councillor Watson, whether you want to ask your question first.
Yeah, okay, I'll take Jeff and then we'll go to that.
I just wonder, Liz, if I keep asking this virtually every time I see you, is any change in the ideas of teachers getting priority for vaccine? I get asked regularly by my constituents about that.
No, I think the answer is still the same. The focus at the moment is on vaccinating those people who are more likely to die from this infection. So all of those people who are in those JCVI cohorts 1 to 9. So obviously we've vaccinated the vast proportion of those people in the first 4 categories, and we're just waiting to find out what the next phase of the rollout is. But really, unless teachers fall into one of those categories, they will need to wait until the next phase of the vaccination programme, and at that point really a decision on whether particular occupational groups are going to be prioritised over others is a political decision, not a clinical one.
Okay, one I've got is, I'll take it to Claire, is the people are barred up at the minute because the weather's so bad, but in a couple of weeks it might be nice and sunny and everybody's going to rush outdoors. And I saw television coverage last night of sledging on the town moor. I don't know if anyone else saw that in Newcastle, and it looked appalling, the numbers of people that were there. And I caught poachers at the weekend, and the police can't do them on poaching, but they're going to do them on COVID. So I just wonder what the crack is, and have the police put out there how many people have fined or caught, because I think that's what's coming down the line. Anybody?
I mean, I don't know what the figures are for police enforcement. I mean, I know they are taking a much stronger approach than they have been, but that's certainly something that I can follow up.
No rush, just to, when this snow melts and calmer weather comes, that's going to be one of the problems. Rachel, do you need? Yeah.
Richard, may I just follow up on that one? It's not just when it's David Thompson here again, sorry. Yeah. It's not just about the improving weather. There are a lot of people now, and increasing numbers of people who have had their first vaccine, and before too long will be getting the second one. So that increasingly large group of people will feel increasingly safe in venturing out. So I'm just wondering if the message needs to be reinforced with that group, who perhaps in themselves feel as if they can get out and about more. Whether there should be some nuances to the engagement strategy, just to inform them, you might have got your vaccine, but please, you must still abide by the rules.
Okay, I've got Claire to come in on that, I think, and then possibly Liz, unless it's an old hand. Claire.
It was just to reassure you, we are actually pushing that message quite strongly, certainly on our socials and in communications that we're doing to remind people that they still do need to follow the rules. And I'm also in regular talks with other communications colleagues in the region who look after the vaccination comms, just to make sure we're all on the same, using the same messages at the same time as well to get that across.
Liz?
Okay, thank you.
Yeah, I mean, I think that's a really good point. I think when people are vaccinated, we just need to make sure that they get that message that actually nothing changes after vaccination. They've still got to socially isolate. They've still got to keep their household contacts to an absolute minimum. And although they all do get a leaflet, and it is in there, I'm not quite sure what proportion of them actually read the leaflet. So actually having that conversation at the time of vaccination is probably the best way of getting that message across.
It's just that I've actually had my jab, and you feel a little bit more confident about going out. So just to reinforce the message that you might have confidence in yourself in going out, but the system needs to make sure that you don't go out. It's just a personal feeling. If a lot of other people think like that.
Well, there's one or two. I've got Jeff Watson, who's already been jabbed, so he might have a view on this as well. But I don't know where you're going to go out to.
Yeah, I just want to reassure you that I had my jab at Anik on Monday, and they at the doctor's GP surgery, and they did certainly say, this doesn't mean that you're safe. You've got to obey all the rules, and please read the leaflet. So if everybody else did what they did to me, then I think we've got that under control. I can't speak outside of what happened to me, but that's my experience.
Okay. Anybody else?
So I think we've just got Rachel to talk in a bit more detail about vaccination.
Do you want me to do the presentation or just give a verbal update? I'm not sure how long you've got. I can obviously circulate the slides or what
how long are you going to be?
I could probably do it in about 10 minutes, 5-10 minutes.
Okay. The first number was better, but go on, get going.
I'll try 5. Okay, no problem. I'll do a whistle stop tour. Okay. Thank you very much. Brilliant. Okay, so here we go. I can't move the slides. Just hang on. It seems to have frozen. That's not helpful, is it?
Plan B then.
Plan B. Oh, there we go, it's moved. So that's still the message is about obviously wait to be asked. This is just a slide. We're still really short of data, but from a North Eastern Yorkshire regional perspective, we've done 500,000 people have now been vaccinated. That's probably gone up slightly. I think what's interesting on here is the split of the work. So 70% of those vaccinations are happening in primary care, 25% in the hospital hubs, and 5% in the mass vaccination sites. And I think that is just interesting. Next slide. We are looking, obviously our priority is the top 4 cohorts in Northumberland. We've now vaccinated 70,000 people within those cohorts, and we are absolutely on target to have offered vaccine to those people within those cohorts by the 15th of February, which is obviously the target that was set by the government. We have had a really bumper supply of vaccine this week, and we will be delivering 17,000 doses this week alone from primary care care in order to achieve the target. Primary care continue to be exceptional, brilliant in how they're dealing with this. They have very little control in the supply of the vaccine, and that makes it really challenging for them to set up clinics and work within that system, and they are still managing to do that very well. We've had some Oxford AstraZeneca vaccine, which has enabled us getting out to those housebound people. It's much easier to move, and it is easier for them to control, and all our care home residents and staff have been offered a vaccine now as part of those cohorts. The hospital hubs are virtually done. Their big focus was around health and social care staff. So Newcastle hospitals have finished theirs. Northumbria actually now have vaccinated 18,000 staff. I just found out this morning, and again they have come to an end, and I think they've been called, they're in hibernation until they get the vaccine for the second doses. CNTW the same, and when the second doses come in early March, they'll start vaccinating again then. Next slide. Just a bit of a view of where we are from a social care staff perspective, looking really good from the numbers that required vaccination and the total that has been vaccinated. Again, that number will have also gone up. It's ever changing, and there's just a description then of the frontline staff in which we have vaccinated through Northumbria. Next the slide just shows the list of all the healthcare professionals that we have managed to pull together, the pharmacists, dentists, etc. The commissioned services, hospices, vocare. There's a number of different people that we are reaching out to make sure that they get a vaccination, and actually brilliant collaborative approach across the system, from all the local committees, local authority, CCG, etc. Next slide. So still a challenge. We obviously have to minimise waste as a priority, and that can be challenging with putting clinics on at short notice due sometimes to the supply being a bit of challenged by the weather and getting people to those. So we are absolutely making sure that we obviously use all the vaccine that comes in. Next slide, please. The national site is obviously at the Centre for Life, and the booking system does cause confusion for patients because they do get a letter that advises them to go to the Centre for Life. What our message is, very much they can choose. They can go to the Centre for Life if they wish, but they can stay locally as well if they'd like to wait, and their local vaccination site will contact them. But it is still helpful for some if that's what they choose to do, and they will continue to send out their national letters. From a vaccine supply, I've kind of mentioned this, it is this push model which is quite difficult, and I've just showed very briefly what our supply has been like in the weeks coming up, and how difficult that has been to kind of flex, but we have done exceptionally well to get a really good load of vaccine into Northumberland, just so that we can make sure we protect our most vulnerable people from COVID. Next slide. So the second dose, we're getting prepared now for thinking about the second dose. This will be given at sort of week 11 plus or minus 7 days. It needs to obviously be done by the 12th week, and we're looking to potentially start that the week of the 8th of March, as the hospital hubs will also do those, and currently it's anticipated that you get the same product as the first dose, but that also may change as we go on. So we're gearing up for that, but not only will we be doing second doses, our understanding is we'll also be continuing to roll out the first doses. Next slide. So this is just what you were just talking about, really, and it is just a reminder that not very much changes when you've had your vaccination. These are the leaflets people get in practice, and this is what people are told, and this is also the messaging for staff. Same rules apply. Next slide, please. So next stage is, we think probably the next cohorts, which are groups 5 to 9, we'll be looking for completion by late spring. We haven't been given a set date for that. We're very much working with primary care to say how sustainable this is. We need to make sure they can deliver their core services. They're very, very committed to the programme. They are working together as practices, which gives them some more capacity. We know they deliver flu very well at their busiest times. What they really want is more control and to enable a pull system so that they can pull the vaccine for when they've got their clinics and plan it a little bit better. And we are told when the second doses come,
come, that the national system is looking to change to that, and that will be certainly very welcome news. Next slide. The other thing we're looking to do to increase our capacity in Northumberland, we obviously, as our geography doesn't really allow itself to have sort of a mass site very easily because it doesn't have a natural centre. So where would we put it? We are still exploring that option. But one thing that primary care is very keen on, and that I think would support our rurality, is some sort of roving model. We're looking at some sort of bus, vans, exploring partnerships with NIAS to see whether we could provide a roving service out of the back of a van or into local village halls as like a pop-up service, so that the vaccines could be taken out to rural communities. It would link in with the work Liz talked about, inequalities, maybe going to some of our hard to reach communities, and that would obviously increase our capacity, and this would look to be doing about 1,000 doses every day. Would it be its capacity, which I think would be really helpful. Community pharmacies are still slowly maybe coming on board as well, and that will also potentially bring some capacity. And again, what we're interested in doing is to work in a collaborative way with our primary care networks, which really have the expertise to do this, equally with community nursing colleagues from Northumbria. Next slide. So the future, just a reminder really around the vaccine, it sort of does take between 4 to 6 weeks before we're likely to see a significant reduction in hospital admissions and deaths amongst our elderly patients, and between 4 to 6 months before we see a significant reduction in community transmission. We're really looking at, requiring sort of 70 to 80% of the population to be immunised, and we're probably at about 12–13% of our population in Northumberland. Initial studies show AstraZeneca vaccine may have a 67% impact on reducing transmission, which is really positive. They're looking at mixing doses. There's more work going on that. Key messages still remain the same. Please wait your turn. Please don't contact primary care. They are extraordinarily busy. Patients will not be missed. They are registered. They're with their practices, and they will absolutely get called when it is their turn. And I think that's it. I'm not sure how long I took, but thank you very much.
Well, it was somewhere between the two, but we have time. Right, any questions for Rachel? Kath?
It's not a question, it's just a statement, just to say thank you to Rachel, who's been the conduit between the local authority and the trust and the primary care networks to ensure that the right staff or the right people within the community are vaccinated at the right time. I can't underestimate, or I can't stress enough how stressful or how challenging that has been on occasions for Rachel, and she is known as the vaccine lady, and I think it's just to express our thanks to her for all the work that she has done over the last few weeks, and will probably continue to do, and she's still smiling, so she's she's loving it really.
I've got Liz Morgan, then I've got a point to make. Liz?
Yeah, I mean, I think clearly the board has received a lot of information over the last hour or so, and I guess for the for the purposes of the minutes, really, I just want some confirmation that the board is assured that the outbreak control plan is effective, and that we're implementing it in the best way that we can. Are there areas that the board feels less assured about? Are there areas for improvement? That I think that would be really helpful for us as a health protection board, because it's the health protection board which I chair, which sort of is actually responsible for delivering the plan. So just getting that assurance from yourselves that you're content with the direction of travel and the way that the whole thing is being managed would be really helpful for us.
Anybody on that point? Anybody not assured that we're doing the right thing? David?
Thank you. Well, yeah, can support that assurance wholeheartedly. And similarly, following from Kath said, the vaccination programme is quite astonishing. But looking ahead, in 1 month's time, there will be tens of thousands of people having their second vaccine, and there'll also be added to that tens of thousands of new people having their first vaccine. So is there any risk, any concern about the capacity and indeed the energy of staff who are doing this, particularly in GP practices and the PCNs? Because it's an astonishing achievement at the moment, but to potentially double up in a month's time and thereafter, might that produce a huge strain on the system and accompanying risks?
Anybody?
Can I take that one, Chair, if that's okay?
Yep.
John Warrington here. I'm a GP in Cramlington and a medical director at the CCG. To be honest, it's the opposite of that. When the amount of vaccine being delivered to primary care networks in the last few weeks took a dip, and all of the primary care networks were really disappointed about that, and were dying to take more vaccination and get on with it. And for that reason, I think there's plenty of energy left in the tank. And crucially, primary care, so that's the primary care networks, these groupings of practices, they want to lead on this, and they want to keep the coordination and the giving of these vaccinations to their own patients. They're very keen to do it, actually, rather than the mass vaccination sites, which are being probably forced on us. Because I think there's nothing quite like jabbing your own patients if they have a question. For example, you've got access to the medical record and so on, and it's just little bits like that that really reassure patients. But to answer the question, I think our nurses, healthcare assistants, and docs and pharmacists back at the ranch, we've got bags of energy, and we want to keep doing this.
Brilliant. I'm always hearing good news. I've got Jeff Watson.
Very quick question. What level of refusals are we having in Northumberland? Is it measurable at all? Are we, you know what I mean by refusals, people who don't want to take the vaccine?
To date, the primary care networks are telling us very few people are refusing, and I suppose you think we have done those older age groups, and certainly from that we've had people turning up very positive and haven't had those problems. I don't know whether we will experience more of that as we go further down the age groups. Care home staff, I think there were some anxieties and worries about that, and we've done quite a lot of work to communicate with them and reassure them. There's been a really lovely little video which Public Health has supported to kind of just encourage people to be vaccinated and the reasons why, which I think has really helped. And I think we're sort of nearly at about 78% of the care home staff, which is a really high percentage of that staff group who often don't take up the flu jab, actually. So it is, quite new for them. So it has been positive overall, and I think it is something we probably do need to be a little bit clearer on as we move down the cohorts. But unfortunately, we just don't see the data locally at that level. And I'm always asking primary care to share that data, and we don't want to burden them too much either, giving us information. But broadly speaking, we haven't had that many people refuse.
Hear that? I mean, I'm quite surprised that we seem to have a problem in care homes. Well, perhaps we don't, but it really hit the news, didn't it, about that Stockton thing? Everybody was talking about. I mean, why on earth would care home people be the people who would be wanting to refuse it when you would think they would be the very people who want to have it in the first place? I just never understood that. And do we have any explanations at all?
Liz?
Yeah, so I think there are a number of different groups who are doing some behavioural insights work with care home staff to just investigate that point. I mean, I think a lot of those staff are younger women, and I think some of the myths that have come out have caused some concern, but often we do find that when part of or somebody from our clinical team or the primary care clinical team has a conversation with them, that actually they can allay those concerns. But it is it's an area where we want to do a bit more digging just to get underneath what the real issues are.
Well, my question was going to be on this very, very subject, because I know Councillor Jones and myself had an email at the weekend from a well-known to us activist, computer warrior behind the screen. It was actually disgusting what is being put out there with people with letters after their names, etc., on their sort of research, inverted commas. I'll say no more, Liz. I will discuss that with you and anybody else, but it's out there and people are putting stuff out that is totally off the mark. I mean, you will be actually shocked by what this bloke is saying. Anyway, that's for a different topic because we're on live. Anybody else on this? What a good session. Jane, Lothian.
So, sorry, just very briefly, on behalf of the practices, thank you to everybody for and we're conveying your thanks at every possible opportunity to the practices. And I think this does make a difference because they have gone above and beyond. And I think that the one role that this board can be is obviously be aware of the potential pressures, but also about the need for the population of Northumberland to act sensibly, to not ignore normal health issues, and to be, to allow for the fact that sort of the practice is trying to sort of undertake business as usual, as well as deliver this vaccination programme. As John and Rachel said, that there's a lot more. I think if it'd been left up to them, they, if the practices would have got it done without any confusion, without the confusion of the mass vaccination sites and everything. But it is going to be a big ask with the double running of the second doses and and the larger numbers. But we still, the main thing for the population health is that people don't sit on problems, basically. So I think that's part of the part of the comms which will be coming, and I know that Claire's been working very carefully on that as well. Yeah. Thank you.
Okay. Thank you, Jane. I have seen no more, so I'm going to move on. That's been a longish session, a lot of information. 4.4, health improvement for Northumberland. Who's taking this one?
Hi, Chair. We've already done that earlier in the session with Dr. Robin Hudson.
Shows you how long we've done it. Right, sorry, 4.5, report of the Executive Director of Adult Social Care and Children's Services. Inspection of local authorities, children's services. Is this you, Paula?
It's actually myself and Graham Writer, so I'll just do a little bit of a spiel. You may remember, well, it feels like it's imprinted on Graham and I's brains, that a year ago we had an Ofsted inspection, and a lot's happened within that year, obviously, and we have had some challenges and issues to deal with over the last year, but we wanted to provide assurance to the board that actually the recommendations that were made within that inspection have been followed up and are being addressed. So I'll hand over to Graham in order to give you an update.
Good morning, colleagues. Just briefly, this cast as a year ago since Ofsted landed on us. They came the last 2 weeks in January and published their report in March. And what they found, they looked at 3 areas of practice: the experience and progress for children needing help and protection, children who are looked after and care leavers, and also the impact of leaders on the quality of practice. And in all areas, Ofsted found and made the judgment that the areas of practice were good in all those, and that's a significant improvement from the previous inspection in 2016. And one of the key findings within that was the quality of the partnership working. And again, if we're going to protect and care for our most vulnerable children, effective partnership working is a key element of that, and that was one of the findings, as well as the quality of direct practice of the local authority staff in that, which I think is a positive. Arising out of that, then there were what the areas for improvement that were identified were around 4 areas, and a lot of that was about the quality of the written work in relation to plans, assessments, management oversight and later life letters. But just want to make the point, as Kath has said, that whilst we got the published report at the end of March, throughout the pandemic, our social work staff have maintained direct face-to-face contact to ensure the safeguarding, protection and care for our most vulnerable children throughout that. So the practice has been maintained. We have done some virtual working in terms of our statutory meetings, such as child protection conferences, and we have used virtual technology, but the direct and critical face-to-face contact has been maintained to reassure the board here about that. And in terms of moving the areas for improvement on, we have put actions in place in relation to all of those areas. And what we also do, our quality assurance, is try to judge the impact of those. So if I briefly go through the plans, the quality of written plans for all children continues to be an area we work to try and improve. The importance of that is making sure that we work with families to develop them there so they contribute to and can clearly understand what is required to ensure their children are safe and that their outcomes are improved. We have seen improvements in that, but there's further planned work that we have in place, implementing our signs of safety, which is an internationally recognised practice framework for working with families collaboratively and cooperatively, and we've got further plans to further improve that there. Similarly, the quality of assessments is important. The assessments are detailed and clear about what is needed to improve the lives and outcomes for our children and young people. And again, we've put development training and in terms of that to improve that. And we've seen that in terms of our quality assurance work that we are seeing as improvements. Sorry.
Is now exiting.
It's all right, keep going.
Yeah, I won't take it personally. The management oversight similarly was about the recording of that. Again, given the nature of the work, it's important that our staff who are engaging in the work have the opportunity to reflect, as well as be helped, supported and guided by our managers. And it was the recording of that that we continue to need to improve. We have seen improvements in that, but we want to make sure that's consistent. But when we speak to all our workers through our quality assurance, they're very appreciative of the support and management oversight that they get. And the final area was later life letters. Now, these are letters that are written for adopted children to read later in life, so they can to help their understanding of their life history and their life stories. I've got to say, Kath and I didn't agree with the Ofsted findings that these needed particular improvement. However, what we have done is we've got a specific team now who are working with adopted children, so fewer and more dedicated staff will be undertaking those later life letters. They follow national guidance. Core and BAF, who are the adoption leads nationally in terms of that, and we're about to do an audit this month in terms of just making sure we're judging the quality and impact of that. So despite the pandemic, we have continued to progress the work in areas for improvement that were identified at the Ofsted inspection. So we've maintained the direct face-to-face practice, and colleagues, I'm happy to take any questions from that.
Right, we'll take questions, but we have to acknowledge the findings and the progress made. So any questions? You're getting off scot-free.
Phew.
Right, can we acknowledge this report? I'll take it that no one's questioned and no one's kicked up, so we acknowledge the report. Thank you.
Thank you, Chair.
On to the next item, which is keep on losing it. Forward plan. Appendix D, as you could imagine, it is dominated by COVID for the next 2 months. I don't think any comment on that. I think these next 2 or 3 months are the turning point. So anybody on forward plan? I see no hands. Thank you. Urgent business, I have none. So I think that's it. Thank you for your attendance. It's been a very informative meeting, and we'll see you in the next month for our next meeting. Okay, thank you all, staff.
Thank you.
Cheers.